All right, so are we all settled?
Yes.
Okay, good. So my name is Laurel Gamm. Oh, you got me. Oh, wow, thank you. Thank you. I'm here representing PNHP Minnesota. It's an organization of over 1,200 health professionals, medical students, and we are a chapter of a national research and education organization of 20,000 physicians, medical students, and other health professionals who support single-payer national health insurance. Single-payer as a term is a little bit wonky. In healthcare, payers are insurers, and health professionals are providers. I really don't like that word, provider. We'll be using the word health professionals all evening, but payer is a word for insurer. So think of single payer as a simplified, expanded Medicare for all, if it's easier to think of it in that way. So we have over 20,000 active physicians on the national level, over 1,200 physicians active in Minnesota. And in a poll in 2009, 60% of Minnesota physicians supported expanded Medicare for all. So we are not alone. I am really grateful to be here. I love coming to New Ulm. I raised my family here. I worked here in New Ulm at the New Ulm Medical Center for over 27 years. It is a great place. I'm grateful too because this is a topic that I care deeply about. And I agree with Martin Luther King, of all forms of inequality, injustice in healthcare is the most shocking and inhumane. I believe this is one of the most important human rights issues of our time. When I started as a young doctor, it didn't take long to see that our healthcare system is broken. There was a big disconnect between what happened in the office when I was talking with a patient about what their care plan might be, what drug to choose, what diagnostic test we might decide to do. But when she left the office, her reality might be completely different, that she couldn't even afford what I had suggested or recommended. And I remember how disturbed I was the first time one of my patients needed to have a community benefit to pay for her health care bills. I decided that to be a true advocate for my patients, I had to advocate for them not only individually in an office setting, in my care for them, but in the political arena as well, fighting for a just healthcare system. I've been involved in PNHP since the early 90s. And in fact, my first presentation that I ever did was at the New Ulm Rotary. And it really is a fond memory, actually, and there were no tomatoes thrown. It was quite fun. But I don't want you to be discouraged when you hear that, because, you know, the early 90s, that's a long time ago. For some of you, it's like, oh, I don't even remember the early 90s. So I want you to realize, though, that, you know, great ideas, right, transformative ideas, they take a long time to come to fruition. So I think this is a great time, especially, as you know, the American Health Care Act just went, and we are thrilled about that. The proposal by the Republicans failed, and now we have the opportunity to do the right thing. We have to decide, do we want to live in a country that allows our people to suffer and die due to lack of health care just because they can't afford it? Or do we want to be in a country that gives each one of us the dignity of having equal access to quality health care and a better chance to lead a healthy life? So full disclosure, I'm not a health economist or a policy analyst. I'm sure there are people in the room that might be more versed in health policy than I am. I'm a physician. I'm here because I'm a keeper of the stories. We're all keepers of stories. And I have patient stories that need to be told. People suffer within this system due to illness. They also suffer because of this system. So I'm here because of Marlene, who came to the emergency department. We'll call her Marlene, okay? She came to the emergency department with stuttering chest pain, and for all the world, seemed like a heart attack. And she said, I just wanted to hold out until I turned 65 in a couple of weeks. Or John, he was a lanky young man that came in with severe flank pain. And all he wanted was some pain relief because he didn't have insurance. He was really scared to be there. And the pain was very unusual and very severe. So I couldn't just treat his pain. I needed to help him find out what was wrong. And so I had to negotiate with him every test because he was so afraid of how this would break him financially. And honestly, I couldn't promise that it wouldn't. He ended up having an unusual tumor. And I'm not sure still to this day which scared him more, the diagnosis or the cost. I'm here because of my sister. She's a single working mother. She has insurance, but she and her daughter have both had medical problems that have led to terrible financial strain. And she's told me, I'm just not going to go to the doctor anymore. So we all have stories to tell, and I think it's really important that we speak up and that we speak out. Some people say real reform just can't happen because of our political divide. People are discouraged, they're even hopeless. But look, we have made really amazing changes in this country when you look back. The suffragettes won the right to vote, right? We passed Medicare, civil rights. We stopped some of the segregation laws and got equal rights under the law, and more recently, the marriage amendment. But in the last decades, as Senator John Marty said in his recent book, Healing Healthcare, which, by the way, is right over there. I have a box of these books. They're quite good. He just would like, if you can give a little donation, $3 to $5. It's an excellent book that he wrote, and he has authored the Minnesota Health Plan. And so he wrote in his book, Healing Healthcare, that we have retreated from a politics of principles to a politics of pragmatism, where politicians calculate what they believe is politically possible and then determine what they stand for. So we end up timid and reticent, sort of working at the edges of a problem when what we need is major change. We just can't sit back any longer and just say that we can't pass legislation that allows our citizens to have equal access to health care because it's not politically feasible. You know, the people around Martin Luther King, they said too, wait, it's not possible. It's not politically feasible. Slow down. Don't go so fast. Take your time. And he wrote a book to respond to them, Why We Can't Wait. And he said the time is always ripe to do right. Yep. So, why we can't wait. So this is when I wanted to start trying a little. I guess you can advance it once more. Trying a little exercise now. So let's say that, let's have all the ones stand up. Okay, so you guys are all uninsured. Okay, the rest of you guys have insurance. Now let's pass that bill that just went belly up. Let's pass that, and I want the twos to stand up. No, the ones stay standing up. All right. We would have doubled the number of people that would have been uninsured in that plan. And we wonder, okay, does it really matter? Does being insured matter? And now intuitively you think it was, but we're a very evidence-based organization. We think, well, let's find out, does it matter? So now, let's see, let's have everybody stand up. Do a little exercising here. Okay, so now you are all uninsured, okay? Now I would like the threes to sit down. Okay. So you have died. Yeah, so actually we've done a study to show that controlling for all other variables, including all your bad habits and any socioeconomic status, any of those variables, people die when they don't have insurance. And all you people that are still standing, you don't bring your kids to the doctor as much. Your asthma is much worse. Your heart disease is much worse. You're much less likely to get care for an acute myocardial infarction. And I could go on and on and on. So you can sit down. I just think sometimes it's helpful when you see people, you realize these statistics are connected to people who have lives. So you can advance it. So this study was done in 2009. Now this would have been about where we would be if that healthcare bill would have passed. 45,000 deaths a year due to lack of insurance. Yeah. Yep. So what about this problem of underinsurance? You guys have all, you get that, uninsured. But this is probably a bigger problem. It certainly affects way more people. The idea that there are an increasing number of Americans who are faced with the problem of underinsurance. They are Americans who carry health insurance coverage, but the actual coverage is poor. If the individual gets sick, they're faced with unaffordable out-of-pocket costs. You can just advance it. I've got a couple more points there. High deductibles, they're going higher all the time. As a result, when people that are underinsured get sick, they stay at home rather than going to doctor and getting the care that they need. And if they do access the care they need when they're sick, the resulting medical expenses can easily bankrupt them. So now I'm going to have all the 1s, 2s, 3s, 4s, 5s, and 6s stand up, please. Do you mind it? Don't do it if you don't want to. I mean, this is... So you guys, that everybody in this room is bankrupt, okay? Just pretend you're bankrupt. Now, all of you are bankrupt because of medical bills. Okay, so it's the leading cause of bankruptcy. 60% of people who are bankrupt because of medical bills. Now I want just the 5s and 6s to sit back down. And all you guys had insurance at the time of your bankrupting illness. So insurance is like, I shrug my shoulders sometimes when somebody says, I've got insurance. It's like an umbrella with holes, in a pouring rain. So you guys can all sit down, but that gives you a sense of what it feels like when your healthcare bills are just out of reach. And most people want to pay their bills. Most people don't just want to walk away from their bills. And so let's always remember that, yes, you can go to the emergency department and get care, but people don't go because they don't want to stiff the emergency department any more than people that go have a restaurant meal don't walk out without paying. Healthcare costs are adding to increasing disparities between the rich and the poor. This is kind of a weird statistic, but bear with me. In 1980, if you were 50 years old and poor, you could expect to live 32 more years. Now, if you're 50 and you're poor, you can expect to live 28 more years. The good news is that if you're rich, you can live 5 more years than you would have in 1980. What about racial disparities? Oh boy, we could have a whole night of just talking about racial disparities. I would encourage you to just even look at the cancer facts and figures for African Americans recently from the American Cancer Society. Among males, incidence and death rates are higher among blacks and whites for all cancers combined, and especially the more common cancers, colon, pancreas, lung, kidney. I'm not being very good about getting you through these, am I? Let's see, where are we now? Yeah, I know, I'm just rolling along here. Oh yeah, you could keep going, let's see. Oh, let's just leave it there. All right, so basically, if you have colon cancer, you're very likely to die about 5 years, if you're black, 5 years sooner than somebody who's white. So this does affect people, right? I'm having a heck of a time advancing my slides. Okay, so this is a comparison of European countries, Canada and the USA, in terms of number of adults that avoid care due to cost. You can see that we're more than twice the second country, France. Next, rapid growth of, and then again, rapid growth of high deductible plans. And again, this was, you can advance. The consequence of having inadequate insurance. 75 million skipped care due to cost. This was a Kaiser study in 2011. 25% with chronic conditions skipped medications. So I think we've established it makes a difference if you can't afford care. You just simply delay or avoid care altogether. So let's talk a little bit about, you can advance, our healthcare system. What does it look like? Now, this can be dizzying, okay, because it's a patchwork, a very fragmented system. You can advance. So private insurance, job-based, okay. Next, private insurance, individual. Medicare, of course, for 65 and older and disabled. Medicare Advantage is a private insurance Medicare. Medical assistance. Minnesota Care for our working poor. The VA for our veterans, the Indian Health Service. Okay. Now you can advance again. So what happened with the ACA? And advance again. We have what we call state exchanges. This was called MNsure in Minnesota. I'm sure, how many of you are familiar with this language? Okay. So basically, it's important to understand that this was just basically a marketplace for private insurance. All right? People could go on this marketplace and they could purchase private insurance, and some people would qualify for a subsidy. Still left about 30 million uninsured. Now, as time went on, that number went down. And so we were down to about 20 million uninsured at this current time. 265,000 Minnesotans. You can advance it. So this is what it looked like. How many of you ever went on the MNsure website? It was very complicated. Of course, they hired people to help you do it, and I encouraged everyone to get a navigator because it was very complex to go through it. But it's a hodgepodge, very many plans that were available. You can advance again. So this was a typical, well, not so typical really. This was for an example, all right? A Minnesota couple, 60 years old, non-smoking, income $62,100, and you can keep advancing. Medica Applause Silver Plan, premium $12,000, out-of-pocket $12,000, and total contribution $25,000, which would be 41% of someone's income. Now, they didn't qualify for a subsidy. They just had earned a little bit too much money for that. Now, that's pretty outrageous. Most people don't end up in this boat, but this is an example of what can happen.
Was that what it was under?
That was what it was. That's what it was. Yep.
I can tell you that it was more than that.
Yeah. So that's not so drastic, huh?
Not so drastic.
Oh, man. Okay. I thought I felt kind of guilty putting that one up, like I was making a big show. Yeah, I know. It's insane, right? I mean, how many people could absorb 41? This is just, that would be just if you happen to get sick, right? I mean, this is not doing anything wrong here to end up with that. I cannot figure out why I cannot advance my slides. I'm sorry. Yeah, let's just, I don't need those things. I don't need this anymore. I wing it. All right, so this is just a quick slide showing the growth in premiums. It's kind of crazy. It's, doubled every 10 years. And needless to say, wages have not come anywhere close to doing anything like this. And if you notice on that slide, this all happened well before the ACA. So these costs were out of control. So let's say, okay, we've got this healthcare system. What are we getting for our crazy dollars, right? So let's talk about U.S. health outcomes. Life expectancy, 28. You've heard all this stuff, right? And sometimes my mind shuts down when I see these numbers. Infant mortality, I believe, 41st. You can keep going down the list there. Overall, we're 37th, right between Slovenia and Croatia or something. And just hold up there a second. But I do get resistant when I see those numbers. I mean, there's a lot that goes into those numbers. And we have fantastic medical care in this country. I mean, if you have the money, there's no place you'd rather be in the whole wide world. And I would even argue that there might be no place you'd rather be than Minnesota. Okay, so I mean, I'm biased. But, so we have great health care. It's not that, it's that it's unaffordable for so many of us. So amenable mortality is a really interesting number. They did this study, and we are the highest rate out of 16 high-income countries. Amenable mortality means preventable death. Things that if you just would have treated them, they would have not died. Okay? But that doesn't mean that that's all from no insurance, right? So I don't want to confuse the issue, but that's a part of it, right? So here's an old slide, 2012. It's now $9,960, I think, per capita, well over our other, Western democracies. And interesting to know, we spend more in public dollars than Canada spends completely. Okay, so just our public dollars. I'm not counting the private stuff. So it's kind of interesting to think about that. Okay, you can advance, see where else we are.
Is the medical treatment comparable?
Quality, there's been a lot of good quality studies. Super duper comparable. We always want to, I mean, you'll hear a lot, it's not as good. I would be in Canada any day of the week and have anything done. It's fabulous. Wait times has been an issue. But they're trying to address that. And remember, if we adopted anything like Canada does, we could outspend them by twice, and we wouldn't have those same kinds of problems. And how many of you have waited for a psychiatrist, a dermatologist, for your children, a child psychiatrist? We have wait times. We just don't call them that. And some people don't have any money, they wait forever. So it's true that there are wait times in Canada for elective procedures. If you need some knees replaced, you may wait a long time that we would think would be astonishing. But they do advertise them province by province. So you can go online and you can find out how long it'll take before you can get in to see a specialist. So these costs are kind of crazy, right? It's kind of mind-boggling. It's over 19% of our GDP that we're spending. And so we want to say, where is the money going, right? What's costing so much? And I'm here to tell you, it is not because people smoke. It's not because they don't eat right. It's not because doctors order too many tests. It's not because, what are some other things you hear? What do you hear about why it's so darn expensive?
Doctors don't charge enough.
Pardon?
No way.
We say, okay, so this is the point. We say, this is what we believe we need to capture, is the business cost of private insurance. This crazy patchwork of insurance we have, that we are spending so much money on these activities of the insurance companies. Advertising, marketing and sales. Every bus you see has an insurance ad on it. Marketing and sales. Underwriting. Huge number of people have to be employed to underwrite, to figure out how much risk you are, and try to figure out how to avoid, right? How to avoid the high-risk people. That's the whole point of insurance making money. I mean, we've handed our health care to the insurance companies. It's not their fault. I mean, it's a great business, but it just doesn't work for health care. Go back.
Sorry,
yeah, that's okay.
I don't know how to go back.
Oh, okay, fine. That's fine. We saw it all. Enrolling, disenrolling, because people just go in and out of insurance all the time. There's gaps all the time. Takes so much money, and then billing, of course, is absolutely crazy. And negotiating provider contracts, all kinds of provider groups all over, everywhere. Executive salaries, well, hey, Stephen Helmsley, United Healthcare, Minnesota, $14 million. That's just his paycheck. Okay, that doesn't count all his options, and it's over $60 million a year that he makes. Lobbying, the number 2 industry that lobbies in America, 160. This is all, just look it up, just Google it, right? $166 million a year that they spend lobbying. They are the number 2 industry, and guess what number 1 is? Pharma. Drugs. Yeah. I see some hands.
We can lump a lot of these together and just say the need for profit.
Yeah, exactly. And and seriously, who would fault a business for wanting to make a profit? It's us that need to say, this is not okay. This is not how we want our healthcare to work. So let's go on. See, there's business costs on the delivery side too, right? So at the hospital and clinic, we've got tons of people employed to handle billing, to do prior authorizations, to do blah, blah, blah. Lots and lots of money. So look at this next here, 21 hours per week per practice. Now that isn't always that the doctor is doing that necessarily, but somebody's helping the doctor do that. 21 hours per week. Canada, 2.5 hours per week. A lot more time to see patients. They did a recent study that showed that more than the time that they spend with patients, doctors spend with the medical record and with prior authorizations and dealing with a lot of the administrative stuff. Quick, this is a little bit old, $871 now per capita for hospital billing. Again, the way they're hospital billing, it's itemized. So every gadget and widget and needle, and it's all listed, and it's very complex billing process. Okay, you can keep going. Okay, don't click it because this is a big drum roll moment. Okay, so this red line shows the number of physicians has been gradually growing over the last 4 decades, okay? And this other shaded area is, now you can do a drum roll and click. This is the number of administrators. So, it's not surprising that this is a huge industry. It's a huge industry. Yeah?
I think that a piece of it also is the fact that there is so much competition to get the patients that actually have insurance.
Oh, yeah, there's all of that.
Organizations,
Sure.
Your Linas and your Mayos or your
And we're
are competing, and they have to advertise.
sure.
They have to find it.
But it's all it's insidious. We'll talk a little bit more about that. And because I got an article today from a friend who talked about that very issue, and we'll talk a little bit more about that. Don't let me forget, because I'm very passionate about that topic. Okay.
Laurel, in terms of cost, medical costs, how do salaries of medical professionals in the United States compare with all of those other countries?
Amazingly well. I mean, now it's true that some of the super subspecialists, I just made that up. Nate, that's not quite a word, super subspecialist. What do you think? Neurosurgery. There's some people that don't fare as well in other countries. I will say there is a more equitable distribution across specialties in other countries because they're more primary care focused in other countries. We could set that up how we want to set that up, but it's true in other countries. It's a little more equitable, but none of us would just snub our noses at the salaries in any of those countries. Now, most of them are fee-for-service. Now, England is really the only place in the big countries that has actual socialized medicine, and they salary all their physicians. The VA salaries their physicians. My husband works for the VA, and they are on salary. Okay, so these two things together make up about 31%. That's a big whopping number of our healthcare dollar that goes to overhead. Now you could even be conservative about this, right? Because you're going to have some administrative overhead for filing claims, right? We're still going to have claims. You're not going to see a bill ever. And I don't even know if you can imagine that. Just imagine that. If you had a life that you never saw a medical bill. It just makes your heart just kind of calm down right there, doesn't it? And that's how it is in other countries. They don't see medical bills. We wouldn't be billing. Yes, there's a bill that goes from the provider to the insurer, and but you don't see it. It's very simple, and Medicare has about a 3% overhead. So yes, there is an overhead, but it's not near the overhead that we're seeing in the private insurance world. So this is about 31% on the dollar, and we can capture that in one fell swoop. Okay, Affordable Care Act, what did it do? It did some good things, right? We got more people on medical assistance. That was huge. 26-year-olds being able to stay on their parents' insurance, that was probably a good deal. They had no pre-existing conditions. Probably find ways around that, but I mean, that was a good thing. And you can just click through these because there you go, no coverage caps. But there's a lot of bad things of this. It's just layers of complexity and the billions of dollars they spent rolling this out. I mean, it didn't need to be that complicated, but it was a compromise, this fun word we have. So it was a compromise, but we end up compromising people's health and their lives. Because the insurance industry, really, they didn't fight this very much. It was a windfall. It's like, you mean you're going to make everybody buy our product? Yeah, which irritated the heck out of me. I'm a little bit leaning sometimes toward libertarian. You know, you're going to make me buy a product that doesn't even work? That doesn't seem fair. But I get it. You have to have everybody in the deal because we're sharing the risk. We've got to share the risk, and that's how it works.
Not the insurance, it's the insurance companies that are sharing the risk. We are not sharing the risk.
Oh, but we are sharing. Well, no, I see what you're saying. Yes, but in the system that we would love to see, yes, we wouldn't be sharing financial risk, but we would be pooling ourselves, I guess is a better way to say it. Yeah. All right. What else we got? Oh, so this is one of the best parts about the ACA was the Section 1332. How many of you know what that is? Innovation waiver. Have you ever heard that term? So we got so excited about this like 3 years, well, in 2010 when the ACA passed, it was like, oh my gosh. Innovation waiver. States get to do what they want. It only has to be better than the ACA, which would be a piece of cake to be better than the ACA in terms of covering people. And so this allows states to do what they want to do. So guess what? Minnesota is fantastic, right? So we're like, okay, we can do this. So let's just stop here for a minute. And before we just jump ahead and say, okay, let's build a health plan, we thought about, well, what are the values that we hold that would make sense in a health plan? Let's leave quality. I mean, quality is obvious, right? But let's go. We'd like it to be simple because it's crazy complicated now. Most of us can't figure out our health insurance. Efficiency. We pride ourselves on being efficient, right? Not a lot of waste, making it sleek, making it transparent. Wouldn't that be wonderful? Because we don't have access. You guys probably don't realize all our medical assistance, all the poor programs, the programs for the poor, are all run through private insurance. We did this back in the 80s in our wisdom. We said it was an experiment and that we would see how that went. And then they would let us know how it was going. And then we, as a state, I'm saying we as a state, would decide whether they should continue doing that. Never happened. So public dollars going to private insurers, your tax dollar going to private insurers to do these public programs. So when Blue Cross Blue Shield, when it started to get cranked up and people were starting to get really angry about this, they gave the state like, I don't know, $31 million or something, just as a gesture, because we don't really want you to look at our books. You know, there's no transparency with private insurance. Okay, so what if we did this? What if we click right through these? Boom, boom, boom. Just keep clicking. We just got rid of all of this. And we replaced it with one payer, okay? And you can click again. Why would Minnesota do this? Why would we be able to think we could pull this off? Well, for one thing, we have amazing medical care here. We have really highly trained professionals. We have great facilities. We have innovative people, lots of entrepreneurs and bright people. And we have, keep going, we have a lot of commitment to each other, right? We have an ethic of caring for one another. I believe that here in Minnesota. And we have, another beautiful thing we have is 5 million people. It's almost a perfect size risk pool. You know, we could just absorb all of us and we would be fine. And it would cost us less than what we're paying now to have this. All right, so what is a single payer? So basically, you can click through these things just a little bit slowly. One unified plan, everybody's on the same plan, covers everything that is medically necessary, okay? Maybe some cosmetic surgery, there might be some private insurance, but basically it's everything. Everybody is in, nobody is out, cradle to grave. It's like enrolling in elementary school. You just sign up, okay? Publicly financed. That means it's financed by all of us. It's not for profit, of course. It's accountable to all of us. And the healthcare delivery, now this is important because this is what differentiates it from socialized medicine. It is not socialized medicine because the healthcare delivery remains private. So you have people competing for different services on reputation, but it's not, the state having the whole system under their. The state doesn't pay the salaries, right? It's like it happens in Canada and most other countries. Like I said, the UK is the only place that has socialized medicine. And by the way, their statistics are some of the best on the planet. So I'm not saying socialized medicine would be a bad thing. I just think we're not proposing that. We're proposing private delivery, okay? And you can keep going. So what is this healthcare fund? You get this healthcare fund that comes, the money comes in, right? And it goes out to these various entities. Goes to I almost said provider. Goes to health professionals. It goes to hospitals. This would be on a global budget because, and you would separate the operating budget from the capital budget so you could kind of manage as a state. You could kind of say, well, Baudette kind of needs this. We don't need 4 MRIs on this corner in Minneapolis, right? So there would be more sense made of where to put these things, right? And then a huge one is the money going for drugs, okay? So pharmaceuticals is a huge issue. I don't know how many of you guys invest in them. I hope you don't. I hope you stop. It's wonderful to have drugs, and don't get me wrong, but the profit margins in these companies is just not okay. Pfizer had a profit margin of 42% last year. Our drugs cost twice as much as the OECD countries average, twice as much. And we can't, and Medicare can't negotiate for drugs. They made a law. They said, no, you can't negotiate. Now, Trump, you'd think he would like a law that says you can negotiate. Yeah, and pharma's lobbying is #1 in the country. 4-point-something billion in the lab. I mean, it's crazy.
So, for the healthcare fund, would that result in increased taxes? Is that where that would come from?
Yeah, you could call it let's just call it a tax.
Yeah, I mean,
Okay, because let's be real, it's a tax. No, that's what I was going to explain. So it would probably be a combination of employer tax and just a progressive tax based on your ability to pay. But we have done a Lewin study. Lewin is a healthcare consulting company that's a subsidiary actually of United Health Group. And they have done modeling for multiple states. They did it in Colorado, they did it in, I can't even remember, I think Oregon, and they did it in Minnesota. And what they discovered that it was for 95% of the population, it was less expensive because remember that you won't be paying all that other stuff. You will no longer have a health insurance premium or a deductible or a copay. We would not want to see any deductibles or copays. And the skin in the game argument is not backed up by science. And that's the part about this organization that I really, really like. It's a very research-based organization. So we try to do evidence-based policy. You know, evidence-based meaning they study this stuff. I don't. But they study it, and they make it make sense rather than just throwing out these.
What's the name of that group that you said?
Oh, Physicians for a National Health Program.
No, but
Oh.
Lewin?
Oh, the Lewin study. So you can also look up the Lewin study.
okay.
Oh, I'm sorry, Lewin. And you know, it was complicated, and they used some modeling. They had different variables and some things. I think they even did have a little. Oh, God, I don't know. Did they have a cigarette tax? Which I think is ridiculous, but they had that in there. I shouldn't say the word ridiculous, but I just don't think it's a good idea to do that. I remember I said that smoking does not cause the healthcare costs in this country to go up. In fact, the sad reality is that people die that smoke, and so they really don't cost the country much, so don't be mad at other people. Yeah, and really, I want to say that I think what insurance companies do brilliantly is they point fingers other places. And the place they like to point them is at the patients. I mean, you know, you don't exercise enough, you don't eat right, you just did that wrong, you did that wrong, you didn't do that, you didn't do that. But it's kind of like Salem witch trials. I mean, that's how primitive what we know now about what causes disease is just not, it's on a thimble, right? Compared to what we're going to know in 100 years. And we're going to think we knew that caused that. And it turns out, no. It's some crazy gene that you've got, and it mixes with this environmental thing, and next thing you know, you're sick. And insurers, I heard this the other day, and I just about blew my top. So they have a term that they use when they got so mad with the whole health insurance exchange. Remember that private insurance piece? It's about 4% of the people in Minnesota, nationally, were on this private insurance, on MNsure. 4%, right? And some people got sick. They got sick, and then the insurers were so mad because they said they created a life event. They used that language that the patient created a life event. Now, I don't know about you, but when I get sick, I don't feel like I'm creating a life event. And that's a very subtle way of saying you messed up. You created your illness, so you suffer. And it's just not that way. And I think we could be nicer to each other about this whole thing about blame and you cost me money and you cost me money and you cost me money. It's not that simple. Yeah.
I just have so the healthcare, this would cover everyone in the whole state. So employers would no longer be offering healthcare coverage. So for them, it's actually, even if you're taxing them, they're not paying out this.
Right, and this DVD right here, I'd encourage you, if you have any business interest whatsoever, this is about what it's like for businesses currently who are trying to deliver. They practically deliver healthcare, to people. It's not the place for it, and they spend tons of money trying to give their people health insurance. So this is really good and talks about how It would be wonderful for businesses. And wouldn't it be wonderful for us? I mean, I was talking to a friend today. She can't stop working because she has to have health insurance, right? I mean, the tail wags the dog all the time, and entrepreneurs just can't be entrepreneurs. Who would dare go out without health insurance, right? Some people do, but
Well, and what Carolyn brought up, I guess, I think I like the idea. I guess I'm cautious, I'm a state employee, and so we do have negotiated health care plans. So part of our compensation package is that they don't pay you as much in salary, but you get the benefit. Now, the question is, if, then the pay, then we're not paid as much as
Well,
someone of commensurate.
right, we'd have to
and-
negotiate, right? Workers would need to negotiate that, but honestly, just think about it. Just think about never having to
Sure, as long as
worry.
I would get the same level of care, like for instance, I have a
Oh, yeah.
daughter that's had to have multiple trips and treatment at Mayo Clinic. If
Yep.
that were not as accessible, I mean, it hasn't been cheap, but I can tell you with our insurance, without it, we would be bankrupt. So
Well,
I want to
you're-
go down.
You're
from
fully insured because Governor Dayton, and I don't know if Stephen Helmsley actually lives in Minnesota, but he would have the same health plan that I would have and you would have. We all would have the same health plan, and it would,
But would it go down from what, I mean, would it level out from what I have?
No,
Or
it would be
would be
probably be
as-
more than what you have. There would be no networks. You wouldn't be in or out of network. You could have a lot more small practices because you would just be negotiating with state for your fee as a small provider. You wouldn't need all these huge. I mean, sometimes the organizations that are big are nice, like Alina, and right. It's nice to have big sometimes. But in some of the small towns across the state, smaller offices could stay in business. No, the idea would be your healthcare would actually be better. We would have much more understanding about what's happening all across the state with people.
So, would there be a fee structure then for procedures?
Yep.
So if you do a physical and then a different doctor does, I mean, would there be, standard rates?
There'd be standard rates.
Or would
Yep.
you be paying for outcomes, which is what Mayo's been.
Oh,
pushing.
so you brought up outcomes. Oh, Nate, I'm so glad you brought. Are there any other health professionals in the room? Because I don't know. Yeah, I recognize you. Yeah. So outcomes.
We have to go find
Mayo's been pushing that route as a.
Okay, so this is just almost, like steam coming out of the ears, because this is another thing that has been touted and like, oh, we'll control costs. We'll just you're going to get what you pay for. We're going to get outcomes. It's really, for one thing, it's really demeaning. Okay, it does.
Question.
Yeah.
How does the federal government view this?
The federal government.
Yes.
With fear, I suppose. I don't know. I mean, people talked about it at the time of the ACA. Everyone always says it's not politically feasible, which I think is just the lamest reason to say something can't happen. I know they're very rich interests involved. Yes, but can I just go back to this, and then I'll stop. Because you need to talk. We need to go back to this outcomes business. Because please don't be fooled by this idea that you're going to go to the doctor and you're going to know whether they have good outcomes, and you're going to be able to measure your doctor by whether they have good outcomes. It's basically, in my view, it's very fancy marketing. You cannot measure outcomes very effectively. How many of you are teachers? I mean, how can you measure outcomes like this? And whose agenda?
You could just not deal with people that have.
Exactly. That's exactly what happens, because doctors, we like to be the best, right? And we look at our partners like, wait a minute, you got good scores. I don't like that. You know, and then the next time that patient wants to see you, gee, don't know if I can see you because your scores, you're going to make my scores lower. I mean, we're human, right? This happens. And the other thing that I think is really sad, probably the worst part of it, is that it becomes my agenda. Okay, so you have diabetes, and we love to see your A1C around 7-ish, right? But you don't really care very much about your A1C, because right now you're dealing with your partner who has dementia. And that's what you wanted to talk about today, all right? But I'm sitting here, I know you got diabetes, and I'm like, oh, I gotta get that A1C down, I gotta make sure your lipids are good. And so it becomes really weird agenda when you're trying to, quote unquote, pay for outcomes. Plus, it's almost impossible because people are complex. And people that have a lot of medical problems, it's hard. It's hard to get better, and it's not the measure of a good physician whether that certain number is on or off. And this is really being touted. Somehow, I can't even figure out, I don't know, maybe you guys know, how this even makes sense as to how this is going to save money. But that's what they're calling it, a cost containment measure. I don't even know, I don't even get the connection there. I guess maybe if we're all healthy, none of us will get sick.
I think the idea is that maybe that we're, you know, not trying to be insulting, but this is what I've heard in discussions on this, that medical providers, or whatever you want to call it, were, because they get paid by, in a sense, the procedure, the code, that they were ordering unnecessary procedures in order to.
Yeah, and I don't know if you've heard this little sentence. I don't know if I can say it right, but it's really quite funny. So the problem with capitation, do you know what capitation is? You get a whole, like I take care of all of you in this room and I get a set amount of money.
Baby was putting the head back.
No, I get a certain amount of money to take care of all of you. No, we don't get it. Face transplant, yes, but so the problem with that is doctors try to see a lot of patients and do less, okay? Fee for service, that's an awful way to pay doctors too, because they just want to see more people and do more stuff. And then there's salaries, of course, because they want to see less people and do less. All right, so I guess the point is there is no pure form of paying anyone, really, I guess. I mean, so fee for service isn't the, I would say fee for service is not the problem any more than capitation is the problem or salaries are the problem. It's just nibbling around the edges, and it's just a way of saying, look over there. Look over there. But don't look at the fact that we have millions. And we have millions thanks to you taxpayers and thanks to all you people who really get sick and can't afford your health care. I mean, it sounds awful, but I think that's really what it amounts to. And I'm going to let Gary talk because and then unless you have to have your meeting.